Hello and welcome to the latest ECHO Palliative Care session hosted by Pallium Canada called Taking Vitals, the Evidence, Development, and Clinical Necessity of a Measure to Routinely Assess Patients' Experience of Compassion. I am your host and moderator, Jeff Moat. I am the CEO of Pallium Canada, and joining us today is our presenter, Shane Sinclair. Next slide, please. Okay, I'd like to take this opportunity to acknowledge the land on which I am presenting from, the city of Ottawa, is the traditional unceded and unsurrendered territory of the Algonquin and Anishinaabe people. The Algonquin peoples have lived on this land since time immemorial. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada, and fervently believe that the work that we do collectively in palliative care can contribute to the healing and decolonizing journey we all share together. We are grateful to have the opportunity to be present in this territory. I'd also like to mention and talk a little bit about the Palliative Care ECHO Project, which is a 5-year national initiative that's designed to support the cultivation and development of communities of practice and establish continuous professional development among healthcare providers right across this country who care for those with a life-limiting illness. If you haven't already had a chance to check out our webpage for the Palliative Care ECHO Project, I certainly encourage you to visit echopalliative.com to learn more information. The Palliative Care ECHO Project is funded by Health Canada, and as a result, all ECHO programming is available to all healthcare professionals free of charge. So I am your host and moderator. At the top, I am the Chief Executive Officer of Pallium Canada. Joining us today is Shane Sinclair, who is an Associate Professor and Cancer Care Research Prof, Director of Compassion Research Lab at the Faculty of Nursing at University of Calgary. Shane, welcome. It's great to have you as part of our ECHO session today.
Thank you.
You're welcome. And in terms of conflicts of interest, Pallium Canada is a registered charitable organization. We have been in operation since 2000. We are partially funded through a contribution by Health Canada. We do generate funds to support our operation and our research and development through our course registration fees and the sale of our Pallium pocketbook. I am a full-time employee of Pallium Canada, and there's no other conflicts of interest to present on behalf of Shane. But this work is supported by the work that Shane's going to be talking about, is supported by a Canadian Institute of Health Research Project Scheme grant number 148543. So in terms of how this webinar is going to be unfolding, we'd certainly encourage you to introduce yourself in the chat function that you can see on your screen there. Everyone's microphone is muted. Doesn't mean we don't want to hear from you, though. There will be time throughout the session to ask questions and to engage in discussion. Please use the Q&A function to ask your questions. That's what it's there for. And do use the chat function if you have any comments or having any technical difficulties. We want to help you out. This session is being recorded. It is going to be available next week. It'll be emailed to you that you can view it again or share it with your colleagues. And that we'd ask, as part of any information that's exchanged through the chat function or the questions that you ask, not to disclose any personal health information during the session. So we look forward to an engaging dialogue. I'm certainly listening to hearing Shane speak about this very interesting topic. And without further ado, Shane, I'm passing the baton over to yourself.
Thank you so much, Jeff, and thank you, Pallium, for inviting me. And thanks to all of you, wherever this finds you in Canada, and I'm guessing also potentially around the world as well. So thank you for being here today. So over the next 45 minutes, I am going to talk to you about the importance of compassion. And really, we have 3 learning objectives, which you can see on your screen here. But by the end of the session, I would very much like you to be able to have a greater understanding of the impact and importance of compassion to quality palliative care specifically. I want to describe the evidence of a new tool that we developed, the Sinclair Compassion Questionnaire, to measure patients' experiences of compassion. And then as well, I want to provide you the skills or the abilities to routinely assess and integrate the SEQ, not only into your clinical practice, but also into your program. So I realize we have a pretty broad audience here, healthcare providers, but policymakers, as well as senior system leaders. So I want to speak to all of you in that regard. Just to sort of tidy up on what Jeff was saying, I will attend to the chat at the end of this session. So feel free throughout this, as things are sort of at the forefront and you remember them, to type them into the chat. I will address them at the end of the session. So don't feel like I'm ignoring you or anything like that. That's just the way that I think we're going to roll today. So let's begin by discussing the importance of compassion in healthcare. And specifically, I'd like to talk about the importance in palliative care. So while compassion has very broad relevance across healthcare, it seems to have particular salience, if you will, in palliative care specifically. And as you can see here, this is the original CHPCA definition of palliative care. It's embedded right there within it. Palliative care is the combination of active and compassionate therapies intended to comfort and support persons who are living with or dying from a progressive life-limiting illness or are bereaved. So while the definition obviously has been modified, I think this is from 1995, the original definition, I think we would all agree it's still very much at the heart of what palliative care is all about, not only here in Canada, but around the world. It undergirds the majority or everything that we do in palliative care in terms of the care we provide. And I think it's also embodied in those famous words that I think we all know by Dame Cicely Saunders, the founder of the modern hospice movement, that care in how it is given can reach the most hidden places. So in general, we know in healthcare that while compassion is prominently featured in healthcare policy, our organizational vision statements, our professional practice guidelines, our professional codes of ethics, and I would probably guess many of the plaques that adorn the hospitals that we work in and the hospices that we work in, compassion is often there right at the very center. However, there's actually very little guidance that's provided to healthcare providers on what it is and how to provide it. Now, this is in spite of the fact that healthcare providers are viewed as the primary conduits for delivering compassion in healthcare, and in turn are often those that are held primarily accountable when compassion is lacking from the patient experience of healthcare. So as a result of this, compassion is a reputed central pillar of quality healthcare, especially in palliative care, that healthcare providers are assumed and expected to provide with very little tools or training on how to exactly do that. Now, while the majority of healthcare providers we know from evidence actually sign up for a career in healthcare for compassionate reasons, i.e. they genuinely desire to provide compassion to their patients, we know that even under the most favorable conditions and their best intentions, that there is often a gap between healthcare providers' good intentions and patients' experiences of compassion. And this is in spite of the fact that there is now a convincing body of literature that demonstrates that compassion specifically, more than routine care, more than empathy, more than patient-centered care, has a very strong positive effect on patients' quality care ratings, their satisfaction with care, and even health outcomes. So let's just take a moment to figure out what is so special about compassion. As we've already talked about, compassion is recognized and there's a growing body of convincing evidence that it's an essential feature of quality care. We also know, however, there's a discord or a gap, as I was saying before, somewhere right here probably, between healthcare providers' desire or expression of compassion and patients' experiences of compassion. We also know there's a tendency for people like me to kind of overrate my ability to provide compassion. That as a healthcare provider, if I were to fill out a survey walking out of a patient's room, I tend to think, that's probably a 9 out of 10 in terms of a compassionate experience. But if you went to that patient themselves, often those ratings are a little bit lower. So we know that there's a little bit of a gap between our good intentions as it relates to compassion and patients' actual experiences. We also know there's a strong positive effect on patient outcomes in terms of compassion, that it has a strong impact on their mental health, their quality care ratings, and even their physical health and pain and symptom ratings in relation to their overall care needs. Now, we haven't even talked about in any way the impact that compassion has on us as healthcare providers. So we know that our ability to provide compassion positively impacts our own well-being as healthcare providers. It helps employers in terms of workplace retention, and it also has a positive impact on our professional and our personal relationships. So in fact, we know that compassion has actually been shown to be one of the most highly desirable traits that humans look for in a potential romantic partner. So if you were nodding off for the first 5 minutes of this conversation, you're now taking notes. Wow, this is something that's really important to my life. If I can pay attention, maybe pull up a few things here, it's going to have a positive impact on my professional practice and apparently on my personal life as well. Now, let's come back to the present and ground this again in our professional practice. I would like you, and you can feel free to put your comments in the chat here in a moment. But what I want you to do just for a couple of moments is I want you to think, I'd like to invite you, whether you're a healthcare provider, whether you're a patient or a former patient, maybe you're a family member, but I want you to think about the most memorable experience that you have ever had in healthcare. So again, depending on where you're coming, this might be different. It might be yesterday if you're a healthcare provider, it might be 20 years ago. It might be an experience that you had as a patient a week ago when you went into your chemotherapy treatment. It might be an experience that you had as a patient 20 years ago that you still carry with you. But I want you to think about what that experience looked like, whether good, whether bad, or whether ugly, whether positive or negative. But it's something that you think about when you think of that question that I just asked. Now, as I mentioned, you can feel free to put your comments in the chat. That's not something that we require. Obviously, needing to take away patient information, so please don't disclose any of that, as we said at the start. But regardless of whether you had a positive experience of a physician who just really took care of you in a personal way, or you had an experience of a healthcare provider, perhaps, who in the way that they disclosed the bad news or the diagnosis, it was done in such a cold and callous kind of way, it stuck with you for many months or many years later. But if you're like most people, I would be willing to bet that compassion is the thread that connects all of those things together, whether it was compassion that was an exemplary form, or as I mentioned, a lack of compassion. So speaking of a lack of compassion, that's when we find the power of compassion actually, I think, is the most noted and has the highest impact. Because we know now that a lack of compassion is significantly associated with increased patient-family complaints, malpractice suits, healthcare costs, the non-disclosure of medical information, and even adverse medical events. And this is information that comes from around the world, including a number of system-wide health reviews in the UK. So compassion specifically has a huge impact in terms of these negative outcomes. And I would venture to guess, and I've had these conversations with directors of medical centers, but if they open up their patient complaint files, sure, there's going to be the botched surgeries and the medications that were administered inappropriately. But when I've had these conversations with folks like that, sort of the biggest file is under C, where it's like a lack of compassion, some behavior that a healthcare provider did or did not do that registered or caused a complaint to be lodged. Now, when it comes to patients' needs and the importance of compassion to the patient experience specifically, the evidence is also becoming clearer and clearer that compassion is one of the most important predictors of patients' overall experience of healthcare. So while healthcare providers identify qualifications and technical skills as the key ingredients of quality care, the opposite is true when we talk to patients, who are more likely to identify the intrinsic qualities and the compassionate behaviors of their healthcare providers as the most important ingredient of quality care, particularly in palliative care and the patient experience. And many of you will know Darren Hyland and colleagues' work on what matters most to individuals at the end of life. Compassion was a unique factor. 96.8% of people said that it was very important or at least important to them. It was the 5th highest endorsed factor out of 28 factors of quality care. But when you take into consideration the other top factors, the other 4, and those were around attributes that are assumed within compassion, things like a healthcare provider that's honest, that's trustworthy, that is understanding and demonstrates respect, I would argue that compassion basically makes a clean sweep of the top 5. Now, when it comes to the patient experience specifically, the 2018 Burrell Institute report on the patient experience found that, in fact, the most important factors are not the typical indicators of the patient experience that many of us have come to know. Things like access, care transitions, the place of care, process, and outcomes. For patients, it is all about the way that they are treated by the people within the healthcare system. The human interactions is really the glue of the entire patient experience. So speaking of patients, let's humanize this a little bit. I'd like you to meet Carl. Pseudonym, and so this is information that I've gleaned over the years. It's based on a real case of an individual that actually Jose Pereira, the chief scientific officer of Pallium, and myself took care of an individual like Carl with a different name. But Carl is a 58-year-old man with metastatic prostate cancer admitted to hospice due to poor pain and symptom management and difficulty managing at home. His home care nurse describes Carl as being non-compliant to medical advice and non-adherent to his medical schedule. Carl is a self-described loner who is divorced and has no children. He's a metal worker, I should say, by trade, and Carl takes pride in his independent spirit and his strong work ethic. While agreeing to the admission, Carl expresses his wish to return home as soon as possible. And since being admitted 2 weeks ago, his pain and symptom issues are now well controlled. But this past week, Carl has been spending much of his days curled up in bed with a flat effect, seemingly disengaged. Now, I imagine many of you have met a person like Carl in your work in palliative care. But a couple of questions that I want us to think about as we work through these slides are these. How might we begin to understand Carl's suffering? So feel free to throw these into the chat. I'm happy to have kind of conversations on the side as I'm going through this. I think this is what these echo sessions are all about. And also the second question that I wanted to ask is, what interventions might we consider as it relates to Carl and this recent behavior of really sort of just being disengaged and staying in his bed all day? But most importantly, or maybe I should say most applicable to our talk today, I want you to think about this question. How might compassion factor into Carl's suffering? And how would we actually know or determine this? And this brings us to one of the most foreboding challenges in improving compassion in healthcare. And that is the lack of a valid and reliable patient-reported measure of compassion to use in both research and in practice. So while the importance of compassion can no longer be denied, we have no way actually of determining when it actually exists, of knowing, as it were, when it enters the room, to prove it in our personal practice and in our organizations. And this is something that we confirmed in our systematic review of compassion measures in healthcare, in which we used a valid and reliable tool for evaluating the measurement of patient-reported outcomes. And when we put these measures into the tool and kind of got the numbers as they came out, these are the results. They indicated that at the time, there were actually no sufficiently robust, valid, and reliable patient-reported measures of compassion. And as you can see there, the highest performing measure scored 32 out of 100 using the MPRO evaluation tool. Now, if you're interested, we actually just did an update to this review using the SEQ, and I'm happy to report that out of the gate, the SEQ is by a large extent the world's most valid and reliable patient-reported compassion measure. Now, the limitations of those measures included poor conceptualizations of compassion. So we actually didn't know what the concept or the construct, if you will, that we were looking to measure was, and the fact that the majority of measures were actually self-report. So again, just to take a moment, basically it was about me as a healthcare provider going in and coming out of the room and really determining just how compassionate I was in that situation. As you can see by the slide we shared around the evidence of compassion, we know that my evaluation of my compassion is often miscalibrated with patients' experiences of that. But as you can see, there's probably a problem related to that. And I often think it's kind of like going to a restaurant and the waiter gives you a customer experience thing to fill out with a pencil. And just as you're about to sort of fill in that first question, he takes it away from you and says, that's not something that you're supposed to do. That's something that I do and the chef does, and we'll determine how good that meal was for you. And so as you can tell, there's some limitations that I think are built into those self-assessments that are inherently problematic. But the greatest reason, as I mentioned, for the lack of a valid and reliable patient-reported measure, ironically, is that nobody actually thought it would be a good idea to go to patients and to actually find out what their experiences and understandings of compassion were. So it was people like me, academics, who were sort of telling us what compassion was, but nobody at that point had actually gone to patients themselves and said, you're the recipients of compassion. You know what it's like, the impact of what happens when it comes into the room. How do you know when your healthcare provider is compassionate? What are the key qualities? What are the key behaviors of a compassionate healthcare provider? How do you understand or define compassion? So in our first CIHR study, that's exactly what we did. We identified the key components of compassion using semi-structured interviews with advanced cancer patients and developed this conceptual model of compassion, identifying the key domains of compassion and how they relate to one another. And really the objective of this was to set the conceptual foundation and to define the construct of interest. So all of these URLs, these references, the papers that I'm showing are open access, so you can feel free to access them at your own pleasure if you're interested in any of these in greater detail. So with this conceptual blueprint and the knowledge of the limitations of existing compassion measures in hand, the objective of our next national study was to develop a valid and reliable patient-reported compassion measure. So this was a 4-year study. It was multi-site. It was funded by CIHR and was led by myself and Dr. Tom Hack at the University of Manitoba. So just very quickly, in stage 1, we really wanted to determine the transferability of that empirical model that I showed you, which we developed with advanced cancer patients. So we wanted to make sure that it was actually applicable in the other settings that we were developing the measure in, namely long-term care, home care, hospice, and acute care. So we did that in stage 1 to verify that, and that was in fact the case. We then in the next year went about the long and arduous process of developing questions or items to ensure that we had a large and robust initial item pool or pool of questions that we were going to whittle down through each of these stages. And in the third stage, after we developed that initial item pool, we convened a Delphi panel of not only international experts on the topic of compassion, but a Delphi panel as well, a second Delphi panel of patient advisors, again, because we believe that patients need to be included at every single stage of our development and our research. And we actually had them as well go through that Delphi process as well to make sure that it was ringing true and integral to their experiences of compassion. So again, we wanted to make sure in this process that the items were representative of the domains that I just showed you and the overarching construct of compassion. In this third stage as well, we conducted, I should say, cognitive interviews with patients themselves to make sure that the questions and the questionnaire was readable, understandable. And we also wanted to validate the question stem or the preamble to each of the questions to make sure that it was valid, as well as the response scale. So I am going to spend a little bit of time here just talking about these two stages, the analysis of structure and reliability, and also construct validation. So these are typically the exploratory factor analysis and the confirmatory factor analysis stages. So if you needed to get a drink, this might be the time. I'm going to spend just a few minutes, a little bit of data heavy slides coming up. But again, the reason I'm doing this is because when we talk about things being evidence-based and being valid and reliable, I think we often don't look at the evidence, or presenters don't provide the evidence, we just adopt them. And I really think it's important for you to have that information in hand. So just very quickly, as I mentioned, these are the sort of first three stages. I'm not going to go through this, but I just share this for those individuals who would like to go and look at this in greater detail. You can really dig into the details of those first three stages that I talked about. I am going to focus on stage 4 and 5, and then we're going to move into the application of the SEQ. So that's kind of where I see us going. So just by way of confessions, I guess you should say, or disclosures at this juncture, and this is really for no other reason than to appease my own flagrant imposter syndrome, which can rage pretty strong on a given day. But just to let you know, I am actually not a statistician, and I am not a measure development expert. So this data that I'm about to show you actually relies heavily on the measure development experts that were a part of our team. So Dr. Tom Hack, Dr. Kara McInnes, Harrison Boss, and my wonderful research coordinator, Priya Jaggi, who oversaw the CFA and EFA analysis and actually helped compose some of the notes that I will be reading from these next couple slides. So again, just to be transparent and to let you know where this is coming from. So quickly, not going to spend a lot of time on this, but really the goals of our stage 4 exploratory factor analysis was to do just that, to do the exploratory factor analysis. We also wanted to assess the retest reliability of the items, which we did 24 hours after administering it to a smaller sample of patients. And then we really were concerned and wanted to balance the measure in such a way that it was clinically feasible while still retaining its strong psychometric characteristics, and also to ensure that qualitative domain coverage. So it was a little bit of a balancing act, because really, if you want to have the most robust psychometrically robust, I should say, measure, you should probably have as many questions as you possibly can fit in there. But I think we would all agree there's nothing particularly compassionate about 100-item, 100-question compassion measure that you administer to palliative care patients at the end of life. So we were really, really careful of finding that sweet spot, as it were. As you can see, the eligibility criteria is here. I'm not going to spend a lot of time talking about that. The data that we collected was from 303 patients, so we wanted to make sure we had statistical power, which we did, and we collected them both in Calgary and Winnipeg from our 4 settings. In the interest of narrowing down the items, so at this point, we had 109 items initially in our initial item pool. We then got it down to 54 items, but we wanted to obviously get that down to a more clinically appropriate amount. So in order to do that, we employed a number of different tests and techniques. First, we narrowed it down by retest reliability. So we got rid of the least performing items in that respect. We completed the exploratory factor analysis as well, which brought it down even further. And with these results in hand, we also removed the least performing duplicate items that got our initial 54 items down to 54. So for those of you that are interested, when you develop questionnaires, you often have items that are intentionally duplicatory. So for example, we had a question that was, my healthcare provider goes the extra mile. My healthcare provider goes beyond the call of duty. So both of those questions were sort of tapping into the same idea of going above and beyond, but we wanted to see which of those items actually performed in the greatest capacity. So not going to spend a ton of time on this, but just to let you know that we were extremely happy with the results that came in terms of our reliability and our validity. And this really got us down to 15 items at this point that we took forward into the confirmatory factor analysis stage. So again, with a Cronbach alpha of 0.961, the reliability and the validity of this measure was coming out with great numbers at this stage. Quickly moving to stage 5, we wanted to confirm the factor structure. So all of this loaded onto one factor, compassion. We wanted to test for convergent and divergent validity to make sure that it was tapping into compassion, but at the same time wasn't just tapping into other things like patient satisfaction. So that's where the test for divergent validity came in. And then we did do some secondary analysis to check differences between demographics and also care settings. So quickly here, we now administer this in a separate group of patients, 330 patients in Calgary and Winnipeg. Same criteria as before in terms of inclusion. So the measures that we administered were demographics, a revised compassion measure. So this is our measure. We also administered the Schwartz Compassionate Care Scale, which is a less rigorous but existing measure that aims at measuring compassion in a clinical setting. We also administered the ESAS, which many of you will be familiar with. And then we also administered the Picker Patient Experience Questionnaire to sort of see how compassion is behaving differently from things like patient experience, for example. So again, we did confirm the unidimensionality of the compassion measure. And here we assess the factor loadings of individual items, model fit, and then, as I mentioned, we assess the convergent and divergent validity of the measure. So in terms of Cfa results, you can see them here. It's available in the paper that I will show you at the end of this if you want to really dig into the details. But the good news is it's a very, very strong. We had excellent fit, excellent validity and reliability, and we did support that unidimensional factor structure of compassion. So in terms of our convergent divergent validity, again, just very quickly, we anticipated and were correct that the Schwartz Compassionate Scale should positively co-vary with our compassion measure, and we found that it did, in fact, co-vary as we expected. And to assess divergent validity, we compared our compassion measure to each of the individual items assessed on the ESAS. And what we found was that there were some correlations. Higher levels of depression were more likely to report lower levels of compassion, but these, again, had very weak indications, but they were significant. So again, the same was true of patient-reported levels of lower well-being correlating with lower levels of compassion. We also anticipated, as you can see there, that the Picker Patient Experience measure should be different in terms of its association. And while these measures were positively associated with moderate to high strength, they were not considered at all to be redundant, as you can see there. So that was something we were happy about as well. So in short, and in summary, and thanks for sticking with me, I'm not a big believer in compassion fatigue. However, having stuck through those slides, I might have to reconsider my position on that. But we did confirm the validity and reliability of the compassion measure. And so let's move to some more interesting things that apply to you probably as a healthcare provider in terms of how this actually works in clinical practice. So what are the implications of the SEQ in practice policy and in future research? So in other words, what do all of those numbers mean in the real world of patient care? So in addition to being the most valid and reliable measure of patients' experiences of compassion, I should say, for research purposes, the SEQ was always intended to be a clinometric like the ESAS, which can be used as a routine measure to assess patients' experiences of compassion in real-time clinical care. So as you can see, we have that 15-item SEQ, which is kind of what we refer to as the gold standard. It went through all of those tests and measurement kind of procedures. But we also developed out of that a 15-item measure of importance, which I'm going to speak a little bit more about, but we administered that in this study that I just mentioned as well. So this allows us to provide individualized patient preferences as it relates to compassion, and for healthcare teams to be able to tailor the compassion that they provide to their patients thereafter, with the SEQ coming in to really assess on a routine basis how we're doing, not only in terms of from last week to this week, but also how are we doing as it relates to that person's preferences of compassion. So I will talk a little bit more about that. We also developed adapted versions, a short form version, which again comes out of the study. So it's highly valid and reliable. So we're not losing a lot of the psychometric robustness in having that 5-item measure, but it's really intended to be embedded in patient satisfaction surveys like the PICR and the HCAHPS in the US, for example, in your own patient experience surveys, to not overwhelm patients with a 15-item measure, which takes all of 2 minutes to administer. But we thought when you're sort of filling out those other things, we want to make it short and nimble. But we also adapted, I should say, versions of the compassion measure for learner needs assessment. So there's a learner's needs assessment that really looks at competencies that learners have, medical students, nursing students, continuing professional education, to understand what are those baseline competence for compassion and how, for example, an education intervention might affect that in terms of a pre-post survey. We also adapted the question stem for short stay hospital, which you'll see in a moment. Outpatient as well, we developed the measure because, again, remember, we developed this measure for people that are in long stay care settings. And we also developed individual healthcare provider measures so that they can, in their own professional practice, for example, a physician, a GP's office, if they want to dial it down to sort of how am I doing, they can do that as well. The SEQ is completely professionally forward back translation in French, so it's available in French and English as per the WHO guidelines. I have a postdoc who is in Spain right now, who's not only doing the translation into Spanish, but she's validating it in a Spanish context. So that'll be forthcoming as well. So let's see how this works by returning to our friend Carl, who I can just remind you of this last week, spent much of his time in bed, flat effect, seemingly disengaged. But the good news is that Carl's hospice care team recently decided to adopt the SEQ as a routine clinical measure, being administered to every patient in the hospice on a weekly basis. So what we find out is that while Carl's SEQ scores were high in previous weeks, the team noted a significant change in a number of items. So here's the SEQ, and here we have Carl's SEQ scores in last week. The care team was kind enough to scan this to me this morning. Unbelievable, really, to do this. Got it to me. This is fresh data from this morning. And as you can see, there's really nothing prolific here on this first page. You can see that most of these things are sort of mapping as they were a week ago to how they are today. But when we get to the second slide, we see a little bit of a change in terms of his experience last week, which he was feeling pretty good in terms of his compassion scores. But when we come to this week, we actually see some drop off, not only here in terms of questions number 11, but we see also here in number 13, that in terms of how Carl experienced his healthcare providers really understanding his needs, he actually is saying he disagrees this week, and how his healthcare, or whether his healthcare providers were able to see things from his perspective. Again, we see a drop off where that is not coming up where we probably would like it. So it turns out upon further investigation that Carl actually had a family meeting last week where he felt that the way his prognosis was communicated to him by the resident was experienced by him as being uncompassionate. And he felt this, that his persistent desire, I should say, to return home was kind of dismissed in this meeting by this resident. So the SEQ really allowed the healthcare team to pick this up And they were able to support the resident in going back and having a follow-up visit with Carl to reestablish rapport and to genuinely listen to his desire to go home. And in doing so, it was discovered that the reason he wanted to go home was to say goodbye to his best friend, his golden retriever, Cedar. Now, while Carl's mobility issues prevented him from going home, unfortunately, the resident and the hospice team was able to arrange for a certain four-legged visitor to come by the hospice and to see his master for one final time. So in addition to providing an overall cumulative average of patients' experiences of compassion, not only this individual, but you could think of this working on a hospice or a palliative care unit to sort of say, how are we doing collectively on a given month? It also allows us to track, much like the ESAS, on a week-by-week basis, how we are doing in terms of individuals' compassion. And then we're able to go back and address them. Now, the really neat thing is that when we pair this with the SEQI, that importance measure that I was talking about, that personalized thing, we are actually able to unlock the ability to identify patients' personalized preferences of compassion. So as you can see here, just very quickly, none of the questions change. These are the same 15 questions, but what we've done and what we did in the study was we changed the question stem. So it's not looking at your experience, but how important are each of these items within the SEQ to you? How important is it to you that your healthcare providers make you feel cared for? So obviously, these are things that are probably going to be highly endorsed by all of us. But there are also going to be some variance that we've seen as well in terms of what are the things that I prefer in comparison to someone like Jeff, for example. And so the same is true of all of those other adapted versions. All of the questions are exactly the same. But because the question stem, in light of our study, looked at people in long stay situations, long-term care, long-term palliative care, hospice, those types of settings, these 7 days won't work for people that are being admitted to emergency or short stay hospital. So we simply change the question stem, knowing that future research will be able to further validate these things as it's being conducted. So that in a nutshell is what those adapted versions are. So the reason we developed the SEQI was, number one, in this study, we wanted to sort of take it for a bit of a test drive to see if it worked. But we also, again, had this commitment to our patients that we didn't just want the top 15 items to be determined by statistical analysis. We felt that patients needed to endorse them as well as being important. And that was in fact the case, that those top items that you see here were the items that patients themselves also said were the most important. But again, we wanted to recognize what we discovered in our other studies, that while compassion, all these things are important, there is variance based on individuals, based on culture, based on gender, that we wanted to be sensitive to picking up. As this one patient told us in a previous study, each individual patient is different. So my compassion levels are different from my husband's because I'm a touchy-feely kind of person, whereas he is not. So for example, while I think we all want to be understood as a patient, or sorry, we all want to be understood as a person and not just a patient. For some patients, inquiries about their personal lives are more welcomed, but for other patients who are maybe a little bit more private, this may not be the case. Likewise, for individuals compassion might be optimally experienced through things like physical touch, acts of holding a person's hand, giving them a hug, whereas other individuals, this may not be how they optimally experience compassion. So as I mentioned, in clinical practice, we envision the SEQ and the SEQI being used in tandem, with the SEQI, for example, the importance measure being used at intake or admission when someone is admitted to our unit, an outpatient clinic, and then the SEQ can be used a week later or in that short stay hospital version every 24 hours. And we're able in that way to really assess how compassionate, the compassion is that we're providing and also to be able to see how that actually aligns with that individual patient's preferences and experiences at baseline. So in the last 15 minutes that we have here, I do want to have some time for question and answers, but let's return to our friend Carl, who actually was administered the SEQI as well at admission. So this was back on June 15th when he came into the hospice. And so now the team is able to compare Carl's personalized preferences for compassion, displayed on the left here, at the point of admission, and to compare these with his experiences of compassion on a weekly basis thereafter, including his most recent compassion scores coming from this morning. Now, again, on this first page, there's nothing that seems overly notable to me as I'm looking at this, just taking a very quick glance. But as we look, to some of the other questions within the SEQ, this is where we start to see some differences. So I want to just two things that I want to highlight here. As you can see here in question number 12, in terms of Carl's experiences, how important is it to you that you have a good relationship with your healthcare provider? Well, interestingly, for Carl, again, he likes to keep to himself. He's kind of matter of the fact kind of guy, really just wants to come in, get his physical needs kind of dealt with, go home. This is actually not that important to him. Now, in knowing this, we as his healthcare providers or his healthcare teams likely don't need to worry so much when Carl lets us know that his experience was not, huge in terms of his relationship, with his healthcare providers. We don't need to sort of flag that with any a great amount of, urgency. It might be something that we obviously want to come back to and not just assume that because he said that, but it's not something in terms of for him that he states is actually that important. But when we get to question 13, how important is it to you that your healthcare providers are able to see things from your perspective? Well, look at this here. Now we see that this is something that he highly endorsed. It was actually most important to him, but he actually is now feeling is the most lacking from his experience. So again, it allows us to follow up, have a conversation with that patient to actually recognize that something is going on here that we were unable to assess previously. So again, obviously, caution needs to be said. We need to be careful and recognize that importance ratings themselves can fluctuate. So for example, when a patient's pain and symptoms are well managed, healthcare providing comfort and being attentive may not actually be ranked as that important because they're doing pretty good. But that doesn't mean that that doesn't become important as they have a pain crisis down the road. So we do need to go back and to look at these things in terms of the importance ratings, but it does provide us a very nice clinical snapshot of kind of how that person prefers or their compassion profile that we can then tailor our care experiences to later. So let's return to our friend Carl and actually Jim, who happens to be the person in the room next to Carl. Why is this important? And again, because I would argue how Carl optimally experiences compassion is different than Jim. Jim, the patient in the room beside Carl, as I mentioned, experiences compassion largely through attributes of warmth, kindness, acceptance, and supportive touch expressed in his healthcare providers in that sort of relational space domain of compassion. So he experiences compassion like this, for example. But for Carl, these expressions of compassion from his healthcare providers are experienced perhaps more like this. So it actually might have an adverse effect on his experience of compassion. So this reminds us as healthcare providers, again, about that gap that we were talking about, that we need to be very careful that we don't assume that how we personally and professionally think that compassion is best expressed is how patients feel or experience compassion is optimally experienced. And so again, it's a way of helping us calibrate or attune our expressions of compassion to that individual. So it allows for us to really dial in, as it were, to those different domains that you see here and to figure out how this person optimally experiences compassion. So as I mentioned, want to leave some time for questions. So in closing, if you're interested in knowing more, you can head over to compassionmeasure.com. And there you will find the SEQ, you'll find video tutorials, resources, adapted versions, which you can download by just simply sort of selecting who you are, individual healthcare provider, if you're a researcher, a care team, or a hospital, and those are all available. So in summary, before we get to some questions, here you have it. Compassion is a reputed hallmark of palliative care and quality care within healthcare in general. Compassion is associated with positive patient health outcomes, satisfaction, quality care ratings, quality of life, patient experience, and improved healthcare provider well-being. But we also know that a lack of compassion is associated with increased patient complaints, healthcare costs, malpractice suits, and adverse patient outcomes. The SEQ, which I've introduced you to today, is a highly valid and reliable patient-reported compassion measure. It's available in both French and English. And when you pair it with the SEQI, the SEQ allows healthcare providers and organizations to monitor, report, improve, and personalize compassion in real-time clinical care. And I would argue, and yeah, sorry.
Shane, you wanted me to remind you it was 12:45. I'm 6 minutes late.
Yeah, no, that's great. Thank you, Jeff. I saw the time and recognize that. Thank you very much. Last bullet. We also think as a team it's really important and would love to see this routinely measured and reported in not only accreditation standards, but we really believe this should be a performance indicator along other performance indicators and a clinometric that should be reported and available perhaps to patients and families. Just very quickly, I think it'd be really cool in, for example, needing to choose a long-term care home to make compassion scores available for each of those homes and allowing families to choose where they would like to place their loved ones based on those compassion scores. So here's where you find the study that's now published in BMJ Open. I'm gonna make sure I stop there, turn it over to Jeff, and maybe have some time for some questions.
That's great. Thanks so much, Shane. Just a fascinating presentation and a very, very interesting topic. And based on the early engagement of our participants, clearly something of great interest to everyone here on the webinar. One of the questions that was asked by one of the participants was how you see this being utilized in a busy acute care setting. The worry is that it would be completed and then hidden in the chart and forgotten about.
Yeah, so those are conversations, those are excellent questions and conversations that we are having and need to have. And I would encourage you, if you think this is something that you want to adopt, to have with those organizations. So this needs to be tailored to those individual care settings. I had a conversation with somebody in New Zealand yesterday and they had the same question, like, how are we going to do this? And I think at bare minimum, we probably want to be doing this in our healthcare settings as people are being discharged to like get an overall sense of what their experiences were. But it can be utilized, again, as healthcare providers and patients see to be fit based on those settings. So in a busy acute care setting, I think it could be administered, you know, every whatever the healthcare team really thinks is appropriate. And in terms of how it's collected, I think that's the other problem is it's one thing to collect data, but then what do you do with it? And so I think we need to get, and I would argue, get these things embedded into EMRs so that they're not just sort of, well, here you go, and it's a piece of paper that ends up in the nursing report room. So how we do that, I think we do need to do some work on that, but I would welcome others to jump in and if they have ideas.
There's also a question in the hospice setting, for instance. You know, the comment was asking patients to complete, you know, weekly surveys can be seen as a burden. Any thoughts or experience on that?
So my experience is that that is not the case. I worked in palliative care exclusively, and obviously I've seen people roll their eyes with the ESAS, you know, being administered every 24 hours of like, oh my goodness. But our experience with this, and remember, this is not being administered every single day, it's being administered every week in a hospice setting. So we were cognizant of that exact question. But my experience is that patients are actually more than willing and like to fill out these sort of questionnaires because it's a breath of fresh air compared to the other things that they fill out. And I think it, you know, just a very small thing, when it comes to research and compassion, we often are, healthcare providers are the greatest barriers to enrolling patients who want to be in trials and qualitative studies in palliative care because we think it's a burden to them. But if we actually go back to those patients, they were like, I wish somebody would have told me this. And so doing this, I would argue, actually, in our experience, has a very strong therapeutic effect for patients. And we have never had an experience of anybody sort of saying, this is overly burdensome. We actually administered 108 items to a small group of palliative care patients. And again, there was some fatigue for some people that set in, but not an overarching issue by any stretch. And most of them actually enjoyed doing this.
Interesting. Some great questions and dialogue going here, Shane, in the Q&A rooms here. Mike McFadden asks, is there a comparative tool to simultaneously measure compassion or satisfaction from care providers? And what about simultaneous study of family members to study concordance with patients, with the patient self-report?
Yeah, so we've been asked about that as well. So I've done some work in pediatric care, for example, where you would probably more likely use a proxy, a parent, for example. But in adult palliative care, that's, I think, a valid question as well. So we are in the process of developing and adapting those types of measures to measure those sort of things. Because obviously, as we talked about, there is sometimes a discordance between family members' experiences of compassion, and particularly when you look at their experiences of compassion in terms of the time point. We know that, for example, when you ask people in the midst of a pain crisis versus 6 months into bereavement, those ratings sometimes get a little bit more rosy, for example. So great question. We are developing some of those things and have some of them available already on our website in terms of individual healthcare provider assessments.
That's good. Shane, Amanda's made some good comments here too. She talked about the only downside with collecting data at discharge is that if there were any areas that could have been enhanced or addressed, the patient's now left. So that's one point. The other point she made, it seems that admission would be the best time, and then a follow-up perhaps the day prior to discharge in an acute setting.
Yeah. So yeah, like when I was saying like at discharge, like I think as I was talking to the person in New Zealand yesterday, I'm like, okay, if you're really that busy, you could do it this way. But I think you're making some good points. Like this really needs to be measured on a routine basis. If in fact, I'm not just a salesperson here today selling compassion, as it were. If this is actually as important as we say it is, and we have the evidence to show this, then this does need to be routinely measured in my mind. And again, we do have those options of the short form SEQ, which is validated and is pretty robust, but the 15 item SEQ takes less than 2 minutes to fill out. So I think it does need to be done on a routine basis, including admission.
Yeah, fantastic. And just for all the participants' information, the copy of the presentation will be made available to you. So that will be coming through and you'll get a link to that. Gloria asks if there's any experience asking patients' families to do the SCQ when the patient is too weak or unable physically to complete them. So
again, I think that relates to the previous question. That's not something that we did in the study because we were very, very strict, but a good question. And I think the closest thing from the study, I believe it was Gloria who asked that question, was we did find that some patients were too tired or did not have the fine motor skills to fill out the paper and pencil survey or to do the tablet. And in those situations, we had a research assistant do it. And in clinical practice, we would recommend that a person other than the healthcare provider do that, like a clerk or a patient care manager, another member of the healthcare team, just to avoid sort of that bias of like, so tell me, how was your experience of compassion today? I'm your physician. Great, you know what I mean? So excellent question.
Shane, $64,000 question. Is this a free resource?
It is a free resource. So it's free for individual healthcare providers. You can download this from the website. Researchers, if you click on that link, it'll come to me just to ask some questions about any opportunities to collaborate, those sort of things. And then for hospitals and things like that, we also intend to make these things completely free. So that's another thing that we have. However, if you're, a big for-profit American hospital, we'd love to have a conversation with you as well, just to keep things like the website running and to keep my students in my lab, that sort of thing happening. So this is something that, free for individual use and for research purposes.
Fantastic. Shane, I think that's going to wrap it up. We're at the top of the hour here. On behalf of Pallium Canada and the Palliative Care ECHO Project, a big thank you for what has been a fantastic presentation. And we often measure the caliber and the quality of the presentation by the level of engagement. And based on what I'm seeing here in the questions and answers in the chat rooms, you've delivered an incredible presentation. So thank you for this. Very, very interesting. For everyone on the call, you will be asked to complete in just a moment a quick survey. Please do so. This information is really helpful for us to ensure that we continue to deliver quality content like what Shane's brought us through today. Complete that survey for us. You'll be getting a link to this presentation and a copy of the slides. So look for that in your inbox shortly. Thank you very much, and thank you, Shane, for your time and for sharing this with us today.
Thank you for having me. Thank you, everyone.
All the best. Take care, everyone.